remind you that this is a multidisciplinary disease, and so our integration with our local therapy colleagues is incredibly important. And it behooves us then for a moment to think about the type of surgery that's appropriate for early breast cancer. And I simply want to remind you that we're at the tail end of a 100-year evolution, that we've come all the way from the thought that one must use very radical surgery to treat early breast cancers, to the thought that the most targeted therapies, lumpectomy with sentinel node localization and radiotherapy, might be the appropriate local therapy for many, many women with breast cancer. How did we come there? Well, we came there because we have 6 randomized trials that have compared mastectomy versus lumpectomy plus radiotherapy, so-called breast conservation therapy. We now have over 20-year follow-up on these trials, and it's pretty clear that there is absolutely no survival difference. And as a consequence of this, a couple of years ago, the NIH consensus conference on this topic actually suggested that breast conservation therapy would be preferred for most women who have early breast cancer. What types of surgeries or local therapies might we consider in addition? Well, I think that these days modified radical mastectomy, with or without reconstruction, is appropriate for some women. Lumpectomy and radiotherapy, as we've just talked about. In certain circumstances, for example, older patients, we might think about lumpectomy alone. And in all of these cases, if we're considering axillary staging, we would normally do it by a sentinel node localization and/or axillary dissection. Now, there are a few circumstances where breast conservation therapy may not be the best kind of surgery, where mastectomy might be preferred. Some of them are shown here. First and foremost is patient preference. If she's well counseled and she wants a mastectomy, I don't think we can stand in her way on that. Poor cosmetic outcome, multifocal disease. An individual like the Hodgkin's disease survivors that Dr. Siegel just talked to you about, who's already had radiotherapy, may not be a good breast conservation candidate. A woman who has an ongoing pregnancy cannot, of course, receive radiotherapy during the course of her pregnancy. And there's a literature that suggests that perhaps women who have connective tissue disorders may also not be good radiotherapy candidates. So these are the things that might bring you as a physician to think about not doing breast conservation therapy. Now, with that brief foray into local therapy, I want to spend the rest of the time thinking about issues that are relevant to medical oncology and adjuvant therapy of breast cancer. And we're going to touch briefly on all of the subjects that you see here, with our first focus being on this whole area of prognostic and predictive markers. Now, you remember that this has pervaded a lot of oncology. In breast cancer, we think of prognostic factors as those things that tell you about the natural history of the breast cancer. And so the traditional prognostic factors have been nodal status, tumor size, the steroid receptor status, particularly estrogen and progesterone receptor status, histologic grade, whether or not the tumor comes in some of these special histologic subtypes like colloid carcinomas or medullary carcinomas, mucinous carcinomas, the proliferative rate, and the age of the patient. Very young patients or very old patients with breast cancer may have a slightly worse prognosis. Now, HER2 is one of the kinds of factors which might be thought of as both prognostic currently, but also it brings us into the thought about predictive factors. And you remember that predictive factors are those that help us select for therapy. So they predict for response to a particular kind of therapy. And the ones that we use routinely in breast cancer are the steroid receptors, estrogen and progesterone receptor status, which predict for response to hormone therapy, and HER2 status, which of course predicts for response to trastuzumab, the monoclonal antibody directed against the HER2 molecule. Now, these things are presented separately, but of course you can see that in practice they are very much blended, that many of these factors might be both predictive and prognostic for the individual patient, and we should consider them together. The other thing I want to remind you about is that we are now moving beyond this thought of looking at 1 or 2 genes at a time. And in fact, we're beginning to embrace the application of expression microarrays for practice in breast cancer. There's a lot of literature out there, which is summarized on this slide. For example, these sorts of things have been able to show us different subtypes of breast cancer on a molecular basis. They've been able to show us that there are different gene expression profiles for those breast cancers that arise in individuals who have hereditary breast cancer, as you just heard about. They've been able to identify for us a subset of young women who have poor prognosis early breast cancer. There's some work looking at these things as a way of trying to predict response to adjuvant or neoadjuvant chemotherapy. And finally, and what's in clinical practice now, is the possibility that you might be able to use these kinds of tests to subset outcomes for women who have node-negative, estrogen receptor positive breast cancer, so individuals where you would think they would have a good prognosis. And there's some interest in whether or not one can use these sorts of profiles to identify those women who are going to do relatively poorly with only the use of adjuvant tamoxifen. This is the so-called Oncotype assay. And I just want to review this with you because it is something that you can order now. It is a part of clinical practice in some cases. And I think it gives us a flavor of how it's going to be for us to apply these kinds of tests as we go forward in our oncology practices. So remember that the substrate here is women with node-negative, receptor-positive breast cancer who got tamoxifen. Our colleagues in the NSABP did a whole series of clinical trials that involved these seemingly good prognosis patients. They took materials that were available from tissues from these women. They did a very extensive gene search algorithm, and what came out of it was an assay called the Oncotype assay, which predicts for you a recurrence score. So this score gives you the likelihood that a patient would have a distant recurrence if she took only tamoxifen. And you can see in this paper that was published in the New England Journal a couple of years ago that individuals who had a low-risk recurrence score had an incredibly good outcome. Those women who had an intermediate score had a less good outcome, and those who had the high-risk score, in fact, had the highest likelihood of having distant recurrence. These investigators were able to look a little bit better, or a little bit more closely, because this was done in the context of trials with fixed types of therapy. And you can see that they were further able to suggest to us that women who had low recurrence score breast cancer had a pretty clear benefit from tamoxifen, and essentially no benefit from the addition of chemotherapy. And you can see that in these curves here. These are 4 different sets of women derived from these trials. You can see that women who took placebo alone had the least good outcome, whereas those who took tamoxifen with or without chemotherapy had basically the same sort of outcome. So low recurrence score would suggest a good benefit from tamoxifen, little benefit from adding on chemotherapy. Now, in the middle were those who had these intermediate risk scores, and you can see that this is a difficult area for us. Same sorts of patient groups. Clearly, the women who took placebo had the least good outcome, but those who took tamoxifen with or without chemotherapy, again, are pretty clustered here, but the numbers of women in this group are pretty small. And then finally, those women who had the high recurrence scores on this assay, you can see had the exact opposite pattern. In fact, they did extremely well with the use of chemotherapy, and the use of hormone therapy or placebo was associated with a less good outcome. So you can see that this kind of assay, if it is widely applicable, might help us to better tailor and target our therapy, our chemotherapy particularly, for those individuals who are the most likely to benefit from it. In fact, I want to remind you that this assay is actually the substrate for a huge national trial that's going on right now, the TAILOR-X trial. It'll be done throughout the United States, focusing again on this large group of women, node-negative, receptor-positive. You're going to give hormone therapy. You're trying to decide what else to do. In this particular trial, women who have a low recurrence score are going to be assigned to take hormone therapy alone as the standard of care. Those women who have a high recurrence score are going to be assigned to take chemotherapy as the standard of care. And for those women who have this intermediate recurrence score, where the benefit of chemotherapy is uncertain, this particular trial will ask those women to be randomized between chemotherapy or not, so that we can sort out this pretty vexing question. So again, this is one of a bunch of kinds of assays like this that are being developed, but I think this is where we're going to see breast cancer practice going in the future, so it behooves us to think about how to use these assays effectively. Now with that, I want to move to my second topic, which is the topic of endocrine therapy, which you know is a very big part of breast cancer treatment. And I want to talk briefly about tamoxifen. I want to talk about estrogen deprivation therapies, which in postmenopausal women is the aromatase inhibitors, and in premenopausal women is ovarian suppression or ovarian ablation. Now, tamoxifen, this is a great drug, right? This is a drug that has really revolutionized breast cancer treatment. And we're reminded of that when we look at the results from the Oxford meta-analysis that were published last year. So remember that this is a collection of all randomized clinical trials done around the world over the last 20 or so years. And here we're looking particularly at the effect of 5 years of tamoxifen in women who have estrogen receptor positive breast cancer. You can see on this side recurrence, and you can see that there's a pretty clear absolute benefit in recurrence rates with the use of 5 years of tamoxifen. There's a lowering here. And you can see that that translates into a mortality advantage, that women who took tamoxifen in aggregate had a lesser chance of dying from breast cancer than those that did not. And it's because of work like this that tamoxifen has become such a mainstay of our breast cancer therapy for early stage disease. In aggregate, to summarize a lot of those studies, I just want to remind you that this is a great drug because it's one dose, 20 milligrams a day. that based on randomized trials, it appears currently that 5 years of therapy is the optimal duration, not longer, not shorter. It is very clear that this kind of drug is only useful for women who have steroid receptor positive breast cancers. There is no benefit to the use of adjuvant tamoxifen if your tumor lacks estrogen and progesterone receptor expression. It's also pretty clear that, unlike some of the other drugs we're going to talk about, that tamoxifen is a drug that is useful in women of any age or any menopausal status. So it's useful across the board for women who have early stage estrogen or progesterone receptor positive breast cancer. Now, one of the areas I'd like you to keep an eye on is some sense that we may be able to better figure out who would be good tamoxifen recipients and who might not be. And in particular, I want to call your attention to the fact that this is a drug that has a very complex metabolism about which we are learning more and more. And you can see tamoxifen up here in the corner. Not doing a good job with my mouse, I'm sorry here. I've lost my arrow. There it is, up in the corner. And you can see that it's metabolized by the cytochrome P450s, a lot of different members of this family. And ultimately, it ends up in part in this structure down here, so-called endoxifen, which is an active metabolite. Now, to get there requires the activity of one of the cytochrome P450s, CYP2D6. And I want you to be aware of the fact that this is an example of where we're beginning to look at polymorphisms in metabolism genes like this and beginning to wonder whether or not this will have an impact on how patients respond to these therapies. So CYP2D6 comes in several different variants. In a study that was done a few years ago, it was shown that your kind of CYP2D6 polymorphism had a pretty direct relationship to the kinds of endoxifen levels that you had. Remember, endoxifen being an active metabolite, which is probably important in tamoxifen's actions. So for example, in this study, most women had the normal variant for CYP2D6, the so-called wild-type variants on both alleles. And you can see that here was their plasma endoxifen concentration, the mean. Some women had a mixed picture, one wild-type, one variant sequence. You can see that their level was smaller. And a few women had two variant sequences, and you can see that they had the smallest endoxifen level. Well, you might say, so, who cares? Well, this may actually be important to us clinically. And to tell you about that, I want to bring your attention to a trial that's tried to look in retrospect at this question. So this is a really old adjuvant therapy trial, done many, many years ago, that focused on postmenopausal women, and the question was one that we now think of as outmoded, which was tamoxifen versus tamoxifen plus one of the androgens, fluoxymestrone. I'll just tell you that the 5-year disease-free survival in both groups was about 80%. The follow-up on this trial is really long. You know that we don't use androgens for the treatment of breast cancer, and this is one of the reasons why we don't. But what this trial did give us a chance to do was to go back and look at these CYP2D6 variants in these women who had been on this trial where we have long follow-up. And here's what came out of that. You can see that we're looking at relapse-free survival with tamoxifen according to the kind of genotype. And I think you can see right away that women who had either one or two wild-type variants, wild-type alleles, did extremely well with the use of tamoxifen. You can see that those that had the variant alleles, 2 copies of it, in fact did reasonably poorly with tamoxifen, perhaps because they can't metabolize to this active metabolite. So this is an area that I'd ask you to keep an eye on because I think we're going to see more and more of this with many of the kinds of the drugs that we give in oncology, and I think this is something that may come up above our radar for tamoxifen in the not-so-distant future. Will it be on the boards? No, but this is to help you think forward about your practices. So this, I think, is an area to watch. It looks like tamoxifen efficacy may be reduced in women who have this polymorphic CYP2D6. It's not clear whether or not we should be getting this and using it to try to steer the use of tamoxifen or not. And I just want to remind you that there are also adverse interactions between some of the antidepressants because of their CYP2D6 activity in addition to tamoxifen, and that is something that is penetrating practice. Now let's turn to the kind of more controversial issues of endocrine therapy, and they have largely to do with whether or not you should do different things than tamoxifen for endocrine responsive breast cancer. And in young women, that means we're going to talk about ovary-targeted therapy. And in older women, we're going to come back in a moment and talk about aromatase inhibitors. So remembering that the ovaries are the primary source of estrogens in young women with breast cancer, you can envision that if you want to target the ovaries, there are several different ways that you could do this. First, of course, you could take the ovaries out. You could use radiotherapy because they're pretty radiosensitive organs. Or you could use the LHRH agonists, which you know are chemical means of leading to a chemical oophorectomy. The other thing I think we need to keep in mind is that we give a lot of chemotherapy to these women, and you know that chemotherapy can also be ovary toxic, and so chemotherapy may also act as a form of indirect ovarian suppression or ablation in young women with breast cancer. When I say suppression, I'm meaning something that's temporary. When I say ablation, I'm meaning an approach that would be permanent. So there's a lot of work that has looked at this for actually a number of decades, the role of ovary-targeted therapy for young women with breast cancer. A lot of studies that have looked at ablation alone, that have compared these approaches to chemotherapy, that have looked at them in addition to chemotherapy, and now are beginning to think about them in conjunction with other types of endocrine therapies. So let's look at that first. Well, I want to remind you that ovarian ablation, either taking the ovaries out or using radiotherapy, is actually a really good adjuvant therapy. And here are very old data that suggest to you that that's the case. This is information, again, from that Oxford analysis that has accumulated our worldwide experience on this subject. Looking at young women, women under the age of 50, who largely we expect were premenopausal, but women who were not selected for their estrogen receptor status, because these are older trials, and looking at the single intervention for these women after their mastectomy as being taking their ovaries out, that's this group, versus no adjuvant therapy, which was the standard there, that's this group. And you can see that this leads to a pretty profound increase in survival, because the endpoint here is mortality. So an increase in survival for these young women with early stage breast cancer. That observation, as well as some other ones, led to a whole series of randomized trials over the last couple of decades that actually looked at whether or not ovary-targeted therapy could substitute.
We have used this panel time to get together to talk about issues in the care of breast cancer patients. It's a complicated topic, and although there are guidelines and standards of care, there's all kinds of different ways of looking at the same information. So I think what I'd like to do is to start by asking our panel, a patient with ductal carcinoma in situ, just some cribiform perhaps, undergoes partial mastectomy, radiation, and then is referred to you for assessment of what's next, in terms of follow-up, tamoxifen therapy or not, and so leaving the question open-ended, I do want to address the issue of, is it mandatory that we ask our pathologists to do hormone sensitivity testing on the DCIS, with the idea that we would use that in terms of making a judgment about tamoxifen use.
Is it on? There we go. So at our institution, we actually do routinely check ER and PR, Bob, and we do that because of the B24 trial, which was the randomized trial of tamoxifen versus placebo, and which was subjected to a retrospective analysis going back and looking at ER and PR in those specimens. It suggests that the benefit of tamoxifen is pretty clear in women who had positive receptors. It suggests that there's not benefit for women who had negative receptors, although the number was very small and the statistical power is therefore pretty small. So some might argue that, it's not a trial that has very powerful evidence. I guess the other place I'm coming from is I don't know of a place in breast cancer where endocrine therapy responsiveness hasn't been pretty tightly correlated with estrogen and progesterone receptor status. I don't know why DCIS would be any different. So we do test it and we do listen to it.
So I'll jump in and say, I think here, in my opinion, this is more like chemo prevention than it is treating real breast cancer.
Oh, yeah.
And because you're probably just as much preventing the contralateral breast from having an event than you are in a radiated ipsilateral breast. However, having said that, I agree absolutely with Nancy, and one reason I do is that at the overview 3 weeks ago, what we saw was, I thought, fairly strong data that if you had an ER negative breast cancer the first time, you're pretty likely to have an ER negative breast cancer in the other breast, not absolutely. And so, again, the issue here is not whether you should use it to select tamoxifen, in my opinion, it's whether you should use it to withhold tamoxifen. And, I believe what you're doing if you treat ER negative, even DCIS patients, is you're exposing patients who are very unlikely to benefit in either their ipsilateral or their contralateral breast with a drug that has, modest cost and modest side effects.
Is there any role, acknowledging the fact that aromatase inhibitors are not FDA approved for prevention, are there ever cases where you would, on a clinical basis, use AIs in the same setting with hormone-positive DCIS?
So I'll take that first. The issue says, I would argue to be very careful about using AIs in this setting, recalling that these patients are very likely to be cured no matter what you do. And I will echo Nancy's concerns in her talk. We don't know what happens when you give somebody an AI for 5 years and then they live for another 5 or 10 years. And it's not like you're taking estrogen levels from here to here. You're taking estrogen levels from here to here. And I believe it's quite possible we may see long-term toxicities with these drugs that we don't imagine right now. And in patients with DCIS, in the absence of good data to support that, I would be quite reluctant to do it. Never. I suppose an occasional patient who develops DCIS will take in tamoxifen, suggesting that tamoxifen wasn't effective, and who is rendered disease-free and would like to take that chance after a long discussion, I think would be appropriate.
I don't have any different opinion. I'm a really, really evidence-based person, and we have no evidence on aromatase inhibitors in ductal carcinoma in situ, nor do we have them in prevention. So I think the default mode is not to use those drugs in those particular settings. Remember these women do extremely well, as Dan said. I think a corollary, Bob, which maybe you were headed towards, is I am frequently asked about using raloxifene or Avista in these women. And the answer to that for DCIS, in my personal view, would also be no, 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 no. Again, we don't have a single shred of information about that particular drug in the setting of DCIS. The only drug where we have a lot of data is tamoxifen. And so that's the drug you should be employing if you think that you want to use some kind of endocrine therapy.
Okay. Let me ask another one or two questions and then open it up for others. Patient with T2 and with 8 lymph nodes positive and was appropriately treated with surgery followed by chemotherapy, did receive radiation, took tamoxifen for 5 years, is now postmenopausal and has been on Femara, took tamoxifen for 3 years and then it was discontinued because of toxicity, depression and so forth. Was on Femara for 5 years. And so the question that I'm getting at is that in someone at high risk for recurrence, how long do people stay on an AI? And do we know that? Do we know that answer to that question?
So you've seen Nancy and me both plead for participation in randomized trials, and boy, if there was ever if we ever needed randomized data, this is the place. And so in those patients who were on MA17, which is of course the study that established using letrozole after 5 years of tamoxifen, patients who got to 5 years were randomly assigned to stopping or continuing even further. I heard this weekend that those patients who would have been eligible for that randomization, 95% or so, have reached the point. And so, and it's something like 60% of the patients who could have been randomized were randomized or something like that. So it's going to be way underpowered. And we're hoping that we will be permitted one way or another to continue to address this question by allowing women who have been on an aromatase inhibitor of some sort for 5 years to be randomly assigned to continuing or stopping at 5 years. That amendment or new protocol we hope will be around in the next few months. But if you have an opportunity to participate in that, please don't assume you already know the answer, because I don't believe you do. And either one of those could be a home run, and either one of those could be fraught with lots of difficulties. So right now, I would stop at 5 years.
Okay. Dr. Hahn, just to ask you, where are we now with limited radiation, mammocyte type, after invasive breast cancer? Partial mastectomy, node negative, very discrete mass that's resected, and in past and present would otherwise be treated with standard whole breast radiation with a boost.
I think you can summarize the data, certainly that led to FDA approval for Mammocyte, as being prospective but limited in number. And so we certainly have chosen, and I don't know what your institutions have done, to use partial breast irradiation on protocol only. That being said, there are certainly indications that you can use in terms of size and location, distance from the surface, to choose partial breast irradiation. My guess is, looking at the sort of non-randomized but prospective data, that we'll be able to select a population where this is a reasonable treatment option. But that being said, until the randomized trials are complete, I don't think that we'll be able to definitively say this. And it should be noted that for some of these partial breast irradiation techniques, especially Mammocyte, that up to 40% of those patients, even when you decide you're going to do Mammocyte, are not eligible for it because of technical aspects, including distance to the skin.
Okay.
Steve, I also heard that in plastic NSAID fashion, that study is almost finished. And so that's great news. I think we should get
Absolutely.
Okay. Question over here?
Yeah, are there any studies that support the how we switch from one aromatase inhibitor to another when a patient progresses on metastatic breast cancer? Is there any studies that support that?
So I think the question is, are there data that a patient who has progressed on one aromatase inhibitor, would she respond to another? And in fact, there are some phase 2 studies out of Great Britain that suggest just that. Part of this depends on what you call respond, because they frequently use both classic response and also disease stability, or so-called clinical benefit. And most common was switching from a triazole to exemestane. And one could imagine where a patient for whom the triazole might not bind to the aromatase as well as the steroid might respond to one and not the other. One might also think that perhaps there's some patients who metabolize the triazole, therefore they may do a steroid, might respond to one or the other. But there aren't a whole lot of data, and I would argue that with the presence of fulvestrant, I usually don't switch from one AI to another on progression. I switch from an AI to fulvestrant on progression.
So I do both. Sometimes I do switch to the other AI. If somebody has really indolent disease, you don't think you're in a big hurry, you're not completely sure that she was progressing in the first place, I'll switch to exemestane as a possibility.
You should
I
be
also-
circulating tumor cells.
No way. I'm not doing circulating tumor cells. Only as part of your trial, Dan. Having said that, I also use fulvestrant in that setting. And then the other research thing that I want to put out for you, which we should keep an eye on, is there is a literature about coming back with these women with this aromatase treatment where they've been estrogen deprived, that if you come back with a teeny bit of estrogen, that actually can be a pretty effective palliative agent. So I bet that in the future you're going to see trials that bring back estrogen, which is a drug that we all thought that we left behind decades ago.
Okay. Question here?
Two questions. One, axillary node dissection versus radiation for micrometastatic disease in the axilla. And two, hormonal therapy for male breast cancer. What should we be doing?
Hormonal therapy for male breast?
So do you mean IHC positive lymph nodes or H&E stain positive micrometastases?
What? Pardon me?
Are you referring to IHC,
Correct,
immunohistochemistry
yes,
positive,
yes.
or H&E,
Immunohistochemical.
cytokeratin positive or H&E positive?
I guess either one. I mean, I had thought of IHC, but I mean, it could be.
So I think the discussion should start off with the notion that there are no prospective randomized data to suggest that treatment of the lymph nodes with radiation or frankly with surgery leads to a survival benefit. That being said, one of the indications for axillary nodal treatment is an undissected axilla. And frequently we see this in the setting of someone who's received neoadjuvant therapy without any assessment of the axilla up front. Usually in the micrometastatic disease setting, because the risks are relatively low of axillary recurrence, it's often omitted from the radiation therapy, but I think it should be individualized. In an undissected axilla, I think it needs to be balanced with respect to the issue of toxicity. And in an undissected axilla, the risk of complications, specifically lymphedema, are relatively low. That risk goes up, of course, when you combine it with level 1, 2, and certainly with level 3 dissections.
Okay. Question?
How do you define postmenopausal status under patient age 50 based on estradiol and FSH level? In younger patient under than 50, how do you define postmenopausal status to decide about hormonal treatment, whether tamoxifen or Femara or Arimidex?
Of course, the easiest is she had her ovaries out. That would be pretty straightforward, but we're not usually quite that lucky. I think that, you know, like Dan, I have been very affected by this case report of Ian Smith's, where he talked about these women who had been amenorrheic for a very long period of time and who ended up having recovery of menses and ended up pregnant, as you heard, when they began an aromatase inhibitor. So in somebody who has been made postmenopausal by her chemotherapy, I personally use tamoxifen. I do not use aromatase inhibitors. I use tamoxifen for a few years. We just sort of see how things are going, and we'll sort it out a little later. But I would not take a 45-year-old, give her chemotherapy, and rely on those hormone levels to tell you that she's postmenopausal and can be safely treated with an AI. I think that's a kind of rocky area right now. I also did do a trial. I was involved in a trial in the United States where we looked at serial hormone levels.
What do you say?
And maybe the assays have improved, but I can tell you that
I haven't
measurement
speak yet.
was really all over the map. And so what you think you're getting back from your lab, you know, they're measuring it for different reasons. They're measuring it to help people with fertility and things like that. And so it may or may not help us with breast cancer management.
Okay.
Yes, understanding that DCIS has not been formally addressed here for the boards, what should I take for the board in summary? What should I know in order to answer those questions correctly?
Because DCIS has not been.
Call your surgeon. I think that'll be option D. Call the radiation oncologist. Actually, I would argue that on the boards, I mean, I don't know what the boards are going to say. I don't write them, but I think what Nancy and I were mumbling is that A, the use of tamoxifen is appropriate. It decreases breast cancer events. Can't hear? It decreases breast cancer events, both in the ipsilateral breast and the contralateral breast. There's very little evidence that improves survival in that setting. In fact, I don't know of any, do you? And that I think it is quite reasonable to use estrogen receptor staining of the in situ cancer to select patients that you would not strongly recommend tamoxifen to.
Okay. Question?
Yes.
I would guess that there might be some basic things like
Sorry.
you probably shouldn't have positive margins, you know, for the DCIS, that the local therapy is going to be important there.
Right. So, I mean, I think it's very similar to invasive cancer with respect to the issue of local therapy. That is, in the absence of a simple mastectomy, right, for DCIS, that's a reasonable alternative, but in the U.S. today, that's a pretty uncommon alternative. So lumpectomy with negative margins followed by radiation. The issue of a boost versus not a boost for DCIS or even partial breast irradiation hasn't been resolved. So whole breast radiotherapy plus or minus to boost in the setting of negative margins. There is an increased risk.
My task is to go over metastatic breast cancer, and indeed, before I even had a chance to come up, 2 or 3 old friends and a couple of people I had not met before walked up and said, "Let me give you a case." And my answer usually is, what's your goal of therapy? And if it's to make them feel better, you can pretty much do what you want to do as long as you're balancing how likely it is you'll make the patient feel better with how likely it is you'll make the patient feel worse. So that raises the issue of what are we trying to do with metastatic breast cancer. And while some of the first part of this talk will be pedantic, especially if you've heard me give this talk before, I find over and over again, I see people coming in that I believe have been overtreated because I believe that her oncologist has not really thought through what the goal of therapy is. And either that or he or she has overestimated what the potential goal of therapy is. Now, of course, for our patients, their first thought is cure. I have a couple of my former fellows in the room, and they'll tell you the first time they're with me and we see a metastatic breast cancer patient, I say, what do you think this patient wants? And they've always sort of been trained ahead of time and say, well, they want to be palliated. I have never seen a patient with newly diagnosed metastatic breast cancer say, well, will you palliate me? They almost always say, I want to be cured. And while that sounds like I'm making a joke, I'm actually not. I wouldn't say that. I'd say, I want to be cured. The issue is we have very little evidence that we cure patients with metastatic breast cancer. I have in the past showed slides from MD Anderson, but I've taken them out, suggesting that of the roughly 10 to 15% of patients that they induced a complete response in using CAF back in the 70s and 80s, about 10% of those remain in continuous disease-free remission for 5 years or more, suggesting that perhaps of those patients who are at least hormone refractory, we cure about 1 or 2%, or at least we keep them disease-free for a substantial longer period of time. In fact, some of those patients probably didn't really have metastatic breast cancer because they didn't biopsy everybody at MD Anderson. We'll talk about that in just a minute. But for all intents and purposes, I think that those patients we do cure, we probably cure almost in spite of what we do and not because of what we do. And there's been no evidence that, for example, aggressive and highly toxic therapy is more likely to lead a patient into being cured than just treating that patient with what makes the most sense to achieve the third goal. Now, there is some evidence that we prolong survival, and if I were writing your boards, I would actually probably ask you something like this. This paper, to my knowledge, has never been published, and that's too bad. I just talked to Steve Chia a couple days ago. But British Columbia is a relatively closed shop. Although they have some immigration, mostly from Asia over the last 10 years, they don't have a lot of emigration, and they practice medicine based on guidelines that the Canadian government lays out pretty strictly, and they have a terrific data set. They have a great outcomes program so they can keep track of what happens to patients and how they're treated. Indeed, their guidelines have said not to do screening analysis for asymptomatic patients who previously had primary breast cancer. As Dr. Davidson said earlier, that there's no evidence to do so. And so what that means is that there's probably very little diagnosis drift here. In other words, we're probably not detecting patients earlier if we see a prolongation of survival. It's probably not because we're just finding them earlier. It's probably real. And while I'm not going to show you the data because I'm relatively limited on time here, what they showed was a stepwise increase on about an every 2-year basis from the late 1980s to the early 2000s in patients who had metastatic breast cancer, suggesting that during that time, with the introduction of several new chemotherapies, the taxanes, capecitabine, several new hormone therapies, in particular the aromatase inhibitors and fulvestrant, and then towards the end of the time period, trastuzumab against HER2, they probably increased overall survival by about 20 to 30% of what it was in the early 1980s. So the suggestion is there is some benefit, but it's not huge because a 20 to 30% increase in survival from a median survival of, say, 20 to 25 months still only results in a few years of median survival, and nothing like what we'd really like to have. So I go back to, I think the main goal of therapy when you're treating a patient with metastatic disease is to make her feel better. And I tell my own patients, what we're trying to do, Mrs. Smith, is keep you feeling as good as you can for as long as you can. And that means picking the therapies most likely to work, means, first of all, making sure you have metastatic breast cancer, then picking the therapies most likely to work, and then assessing whether they are working or not. One of the things that I really make it clear to our fellows is, first and foremost, establish the diagnosis. I rarely assume that a patient has metastatic disease based on symptoms or radiographs alone, and that's because I would guess 10 or 15% of the time I'm wrong when I do so. So if at all possible, I try to biopsy a metastasis. Now, it's not always possible, or the data are just so overwhelmingly compelling. For example, a patient who's got new pain, has multiple bony sites, you take x-rays and they're all lytic, and she's got a liver full of abnormalities. Yes, that's probably metastatic breast cancer, especially if she had breast cancer 2 years or 3 years ago. But if there's any question at all, I make every effort to do a biopsy, and especially if they're pulmonary lesions. And I can tell you that pulmonary lesions have the highest rate of false positivity, and it's really important, I think, to make sure. Second of all is to establish the prognosis. And the reason why is that although my philosophical discussions earlier in this talk are notwithstanding, there are some patients in whom more aggressive and toxic therapy up front probably is life-saving, and those are patients who have rapidly progressive visceral disease. And I would combine those two phrases, rapidly progressive and visceral disease. I have seen a number of women who have been told, you have liver mets, we should bypass hormone therapy even if you're ER positive and go right to chemotherapy because you have visceral disease. Well, that's actually not appropriate in my opinion. I have a number of patients who've had liver metastasis do quite well for long periods of time on endocrine therapy alone, assuming that they didn't have rapidly progressive visceral disease with end organ dysfunction. So the most important prognostic factors are time to treatment failure, especially if prior adjuvant therapy, the site of the disease, visceral or not, and various tumor characteristics still hold true, especially in terms of prognosis, but also in terms of prediction, we'll talk about in just a minute. And I'd like to briefly talk about some new stuff that we've been involved with. It's called Cell Search, and these are data that we published. Massimo Cristofanelli was the first author. We published in the New England Journal about 2 years ago, in which we did a prospective study of 170 patients, 177 actually, who had metastatic disease or were going to start a new therapy, and we looked at circulating tumor cells before they got their new treatment. And what you can see here is that the green line are those patients who did not have elevated CTCs, and the red line are those patients who did in regards to progression-free survival, suggesting that pre-treatment CTCs were highly prognostic. And then we looked at the second set with no monkey business. We said, okay, we've developed our algorithm in the first set, we'll apply it to the second set, and got almost exactly the same results. And we thought that was pretty cool, and now we're trying to figure out exactly how to use that. I would not, at this time, use circulating tumor cells, for example, to bypass hormone therapy and go to chemotherapy. Dr. Cristofanelli does believe that, and he and I disagree. But I think it's an interesting observation. I think we're going to find circulating tumor cells finding their place in the clinical arena in the near future, and I'll talk about that in just a minute. And then finally, establish the likelihood of response. And of course, Dr. Davidson already talked to you about classic predictive factors, and they pertain in the metastatic setting as well as in the adjuvant setting. And those are ER for endocrine therapy and maybe HER2. There is evidence that HER2 overexpression and amplification may actually result in resistance to either all hormone therapies or perhaps to the SERMs, tamoxifen in particular. For chemotherapy, actually, we've had very few predictive factors, performance status and maybe prior treatment. There are some data that using in vitro assays for chemotherapy sensitivity and resistance might be a thing to do. In an ASCO technology assessment panel, however, they decided that the data just weren't sufficient to make a recommendation on a routine basis for that. And right now, I certainly do not try to send tissue off for chemotherapy resistance. And then finally, of course, HER2 for trastuzumab. And these are the data from the late Bill McGuire, just establishing the whole concept of predictive factors in oncology, particularly related to ER and PR and breast cancer. And there are other predictive factors for chemotherapy. Performance status, of course, is great. Prior chemotherapy. It's not at all clear, though, if prior chemotherapy less than 12 months predicts for resistance to some of the newer therapies like taxanes. The data just have not been published. Most of the data come from the older studies of CMF and AC, suggesting that if you relapsed within 12 months, you would be resistant to further treatment with one of those. I think it's likely with taxanes, and likely with capecitabine, and likely with gemcitabine, but I actually haven't seen any data to that. And I talked about in vitro assays, and they're not routinely recommended by the ASCO Ad Hoc Technology Assessment Committee. So these are our treatment algorithms. As you have a recurrence, you initially make the diagnosis, and then you decide prognosis. Either a patient has relatively indolent disease, and most do. If they have a single site focal symptoms, one might choose local therapy in order to get the patient out of pain or to avoid an impending bone marrow spinal cord compression. If they have multiple and rapidly progressive visceral sites, then you might go to combination chemotherapy. But on the most part, I would pick single modality therapy. And if we had systemic therapy, then again, if they're positive for ER and PR and have a long disease-free interval and appear to be responding to the preceding ET, then I would go with endocrine therapy. Again, if they're either negative for ER and PR, a short disease-free interval, or refractory to endocrine therapy, then I would go to chemotherapy. If they're ER positive, we would add trastuzumab. And if they had bone metastasis, we'd add bisphosphonates. Now, once you've made your best bet, was it the right one? And I find that to be one of the most challenging issues in treating patients with metastatic disease is how long do I stick with the horse I started to ride in the first place? One can use history and physical examination, but they're notoriously unreliable. One can use imaging, but they often take as long as 2 to 3 months to decide whether or not a patient is or is not progressing. And more recently now we have, well, not more recently, we have serological markers, and they are quite helpful, but again, usually only later in a patient's course, and circulating tumor cells. Now, this is an example of a CA15-3 from a patient of mine who initiated therapy, in this case chemotherapy, and over the first 4 to 8 weeks, her 15-3 actually increased to a zenith here, and then began to drop back down again, and ultimately dropped below what it was when she started. This patient was relatively symptomatic here. By 8 to 12 weeks, she was already becoming increasingly less symptomatic, and yet it took her marker a long time to reflect that. Out here, the marker was quite helpful because with time it began to go up and she was having symptoms I couldn't quite sort out, and ultimately I decided she was progressing. But the point here is that soluble tumor markers often have this spike, maybe as often as 25% of the time. They can last anywhere from 2 to 8 to 10 weeks and give you a false positive for progression, and the wrong answer for this lady would have been for me to change hormone therapy and go to chemotherapy. Actually, I said I started chemotherapy, I started hormone therapy in her. So we got excited about looking at CTCs. It turns out that circulating tumor cells at first follow-up do not have this spike I just showed you. And so these are data that look very similar to the data I showed you before, except in this case now, we've drawn the circulating tumor cell at first follow-up after starting a new therapy, this blue line. And what you can see here is that time progression is quite short from the time we drew that line. 50% of those patients with elevated circulating tumor cells had progressed within the next month or so, whereas if they didn't have elevated circulating tumor cells, they had a relatively long time to when they progressed. Now, there are two issues about that. One is that most of these patients do have rapid progression if they're on that red line. However, I don't know that changing therapy early, which is a real paradigm changer for me at least, would do those patients any good. Perhaps this is the 20 or 30% of patients for whom no chemotherapy is going to work and they're just going to go on and progress on everything. Or the alternative is I just started the wrong therapy, they happen to be resistant to that therapy, and the good news is they have metastatic breast cancer and there are multiple other options to try. The other is some of these patients don't progress rapidly, and I would presume that changing therapy on them right away would not do them any good. So in the Southwest Oncology Group, we're about to open a study. It'll be open on the CTSU, and I would hope many of you would participate in this study, in which a patient with metastatic breast cancer who's going to start first-line chemotherapy, so this is first chemotherapy in metastatic breast cancer, will be profiled with circulating tumor cells. If she does not have elevated cells, you can start her on whatever she's on and she's not on the study. But if she does have elevated circulating tumor cells before she starts therapy, you pick whatever therapy you want, give her one cycle, and we'll test the cells again at about 3 to 4 weeks after she's had her first cycle. And if she's cleared her cells, and about 20% of patients will clear their cells, then that patient remains on whatever you chose, presumably you chose correctly. If she doesn't clear her cells, though, then those patients will be randomly assigned to staying on what they're on until they have classic signs of progression, which would be standard of care right now, or switching to a different chemotherapy of your choice right then, as opposed to waiting until she becomes symptomatic or until you have classic evidence of radiographic progression. That study is now open. It's available on CTSU. It's going into several IRBs right now as we speak. Now let's talk about some special considerations regarding the treatment of metastatic breast cancer. The first of those is bisphosphonates. They are clearly here to stay. They clearly reduce bone complications in patients with metastatic disease. And I believe every patient with metastatic breast cancer to bone should be started on some sort of bisphosphonate. I don't believe there's any evidence to suggest that one is better than the other in terms of the intravenous bisphosphonates, whether it's pamidronate or zolidronate. You can't get clodronate in this country. In Europe, it's an oral agent and it's used quite often. One of the questions I get asked quite frequently, though, is when should you start a bisphosphonate? And while I generally say any patient who has a bone metastasis should start, I must say that in the occasional patient, for example, who might have a sternal metastasis only and who is otherwise not going to be on intravenous therapy, say I'm going to place her on an oral hormone therapy, I hate to tether that patient to me with intravenous therapy on a monthly basis, and will probably irradiate that site as well. So that patient, I don't necessarily start on bisphosphonates right away. But if a patient has a distant site or more than one site, then I begin it. I think the second question is should they be continued after they've had a new complication? And I just asked Gabe Hortabaji, whose name you'll see here, that very question yesterday in Seattle. Actually, it was Saturday. And his answer was, we don't know, we've never tested it, and nobody really knows. And so the default is, since we believe in treating people all the time, 24 hours a day, we usually go ahead and treat people. I personally do continue the treatment from one systemic therapy to the next until the patient ultimately dies. But I'm not sure that's right. In the past, it seemed like all I was costing them was the intravenous therapy and the money. But of course, now we have this new osteonecrosis of the jaw. It looks like it's going to be somewhere between 1% and 5%. There are now registries, again, Gabe Hortabaji has a registry in press now suggesting that it's as often as 1%. Part of the problem is the definition of osteonecrosis of the jaw, and it's not entirely